America is in the middle of a heroin epidemic. In July 2017, the President's Commission on Combating Drug Addiction and the Opioid Crisis issued a preliminary report stating that its first and most urgent recommendation is for the President to declare a national emergency. The Commission, led by New Jersey Governor Chris Christie, states that the goal of such a declaration would be to force Congress to focus on funding and to awaken every American to the simple fact: if this scourge has not found you or your family yet, without bold actions by everyone, it soon will.
142 Americans are dying every day of a drug overdose. To put that in context for everyone, that's having the equivalent of the death toll on September 11th every 3 weeks in America.
142 Americans die every day from drug overdoses. Heroin is a white crystalline narcotic powder that is derived from morphine. Morphine, in turn, is isolated from a plant, the opium poppy. Heroin was used to treat pain as an analgesic, and it was also used as a sedative. Its origins go back to Germany in the late 1800s. Today, of course, it is illegal and highly addictive. Today we're going to talk about heroin in the context of addiction. Let's first concentrate on addiction in general. Later we will focus on heroin itself. So why should we care about this disease of addiction? 540,000 Americans die every year from addiction. When all costs are considered, addiction costs America over $500 billion each year. That's $500 billion. Only about 8% of addicts are the stereotypical Skid Row street addicts. You might picture a homeless person living under a bridge. So who are all the other addicts? Where are all the other addicts? Well, they are the people that you see every day. They are your friends, your family, your neighbors, people in your community. What is addiction? The best definition comes from the National Institute of Drug Abuse. It states that addiction is a chronic relapsing brain disease that is characterized by compulsive drug seeking and use despite negative consequences. So we immediately see that addiction is a chronic brain disease. It is not a moral defect or a simple issue of willpower. Medical diseases are diagnosed and addiction is no different. In order to make the diagnosis, we need to examine the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. This manual is published by the American Psychiatric Association, and it lists 11 criteria for addiction. If someone answers yes to 2 or more of these, they are then diagnosed as an addict. The DSM-5 goes on to describe the severity of the disease. 2 to 3 criteria is considered mild, 4 to 5 moderate, and 6 or more is severe disease. The incidence of addiction in the U.S. is about 10% of our population. There are other quick screen questions that are sometimes used. As an example, for alcoholism, the CAGE questionnaire can be used, C-A-G-E. Those letters stand for 4 questions. Have you ever felt you should cut down on your use? Have people annoyed you with criticism over your use? Have you ever felt guilty about drinking? And have you ever had an eye-opener first thing in the morning? If someone answers positively to 2 or more of these questions, that is an indication that the individual has a problem with alcohol and will require a more complete evaluation. It does not diagnose alcoholism, but it's a quick screen that can be done. There's a large amount of scientific literature that indicates and strongly supports the idea that addiction is a brain disease with a significant genetic component. Let's examine a few of the early studies. Remember, alcohol is a drug, so when we look at addiction, alcoholism is included. The general conclusions from studies with alcohol are usually valid for addiction to other drugs as well. Twin studies have been done using identical twins. If you want to examine any genetic characteristic or trait, identical twins are a good place to start. These studies show that there is about a 70% concordance when it comes to addiction, meaning if one identical twin has a problem with addiction, there's about a 70% chance the other one will as well. Adoption studies have also been done. For example, let's say 2 alcoholics have a child. That child is put up for adoption. That child goes into a home where alcohol is not an issue. In fact, the parents may not drink at all. Studies show the chances the child will develop a problem with alcohol are 4 times higher compared to baseline. Many of these adopted children will become alcoholics later in life because of their biological parents, because of their genetics. This happens even when their home environment is free of alcohol. There is no doubt that addiction has a large genetic component. The environment matters, but not nearly as much as genetics. Static ataxia studies have also been done. In these studies, sons of alcoholics who had never had alcohol in their lives were given a small amount of alcohol. The ones who had a family history of alcoholism, so alcoholism was probably in their genetics, drank the alcohol and acted relatively normal. The sons who didn't have alcoholism in the family took the drink of alcohol and they acted drunk. They slurred their speech, they swayed from side to side, so the alcohol really affected them. What that shows is that these sons were different from the start. Because of their genetics, they handled alcohol better. They had a kind of built-in tolerance. And that was different for the boys in the study who did not have alcoholic genetics. And finally, EEG studies were done which showed you can identify those who have addiction genetics simply by examining their brain waves. Again, these early studies were not perfect, but they did point us in the direction of addiction as a genetic brain disease instead of a character defect or weakness. In recent years, much more complex studies have been done using advanced imaging and laboratory techniques. These new studies typically support this well-accepted disease model of addiction. So let's look at addiction in a simplified way. If genetics and environment align, addiction involves the parts of the brain responsible for reward and survival. These are dopamine-mediated pathways. Dopamine is the feel-good chemical in the brain. Imagine you went 3 days without water. At the end of those 3 days, you would not think rationally, and that thirst would rule your thoughts and actions. That's like a craving that drug addicts have. It's the same mechanism for addiction. Willpower no longer plays a role. A very thirsty person would do anything they had to do to get a drink of water, and that's very much how addicts report feeling. They cannot mentally control thirst, just as addicts cannot decide to not be addicted. Look at these 2 pictures. This is the same person 4 years later. When we look at that picture, we think that person looks sick. We do not think that they are immoral. We do not think of the word junkie. We think this person is sick. and they are. This is what 4 years of crystal methamphetamine use can do to someone. The same goes for this picture, the same person showing the effects of drugs a few years later. So again, this is a disease. These people are sick and they need help. Addiction is a perfect storm of genetics, life stressors, timing, and access to the drug of choice. When those factors align in someone's life, you get this perfect storm of turmoil and pain and everything that goes along with addiction. This is an ugly disease that is ultimately fatal if not treated properly. There is often significant denial. The addict denies having a problem and refuses treatment, even though treatment in some form is almost always required. Now that we have covered some addiction basics, let's specifically discuss heroin. Heroin is an opioid drug synthesized from morphine. Morphine is a naturally occurring substance extracted from the seed pod of the Asian origin opium poppy plant. Most of the heroin comes to us in the United States from Mexico and Colombia. What is the scope of this problem? Let's examine the numbers. According to the National Survey on Drug Use and Health and the UN Office of Drugs and Crime, in 2012, 670,000 Americans reported heroin use sometime in the past year. In 2014, there were about 1 million heroin users in the United States. The greatest increase in use is in young adults aged 18 to 25. And deaths related to heroin use shot up 5-fold from 2000 to 2014. Essentially, 1 of every 4 addicts who present for treatment are addicted to heroin. In 2011, an astonishing 42 million Americans used heroin at least once in their life. These are alarming increases in heroin treatment and use. Heroin can be injected, snorted, or smoked. All 3 methods carry it to the brain very quickly. Once it is in the brain, what happens and how does it act? We call this a mechanism of action. The brain converts heroin back into morphine. The morphine then attaches to receptors on the brain cell surface. These are called mu-opioid receptors. And that produces a neurotransmitter called dopamine. Dopamine is the feel-good chemical in the brain. It produces the intense feeling of pleasure. Much of this occurs in the brain stem, the same place where our areas for reward and survival are located. Once the dopamine is released in the brain, the user experiences several different effects. Some are short-term, some are long-term. The user experiences a rush. That's the intensely good feeling that happens right after use. Depressed respiration occurs, meaning the user's breathing is suppressed. The other short-term effects include miscarriage, decreased pain, mental cloudiness, nausea, vomiting, and sexual dysfunction. Heroin often has toxic additives that lead to numerous health problems, again both short and long-term. The long-term effects include tolerance, which means it takes more and more of the drug to achieve the same effect, dependence, which means that the person has withdrawal symptoms if they do not have the drug in their system, deterioration of certain parts of the brain itself, impaired decision-making, behavioral problems, impaired response to stress, collapsed veins, and constipation. Notice that other than the rush and pain control, all of the other effects are harmful. Because heroin can be injected, it is important to discuss infectious diseases. Heroin users often participate in high-risk behaviors like needle sharing and unprotected sex. These behaviors can lead to transmission of blood-borne viruses like HIV, hepatitis B, and hepatitis C. Hepatitis C, for example, is the most common blood-borne infection in the United States. If heroin has been around for over 100 years, then why are we just starting to talk about a heroin epidemic? What factors contribute to this epidemic? What do we do about it? How do we treat it? And even more importantly, how do we prevent it? First, let's look at access. Many people assume heroin is a big city problem, but it's not. Heroin is everywhere. There has recently been a significant increase in small-town overdose and death. Heroin is also inexpensive, sometimes as little as $5 or $10 per use. So when you have an increased demand that is met in an inexpensive manner, it can lead to these epidemic-type numbers we see today. The purity of heroin has also changed significantly through the years. In the 1970s and 1980s, heroin might have been 20% pure on the street. Now it can be up to 90% pure in some areas. Heroin is sometimes mixed with or cut with active substances like fentanyl. Fentanyl is 80 to 100 times more potent than morphine. This is a deadly combination which can lead to overdose and death. Next, we have to look at prescription opioids. These are drugs like Vicodin, OxyContin, and Demerol. 50 Americans die every day from prescription pain medication overdoses. Approximately 80% of heroin users report previous use of prescription opioids. We have a simultaneous crisis of prescription opioid addiction in the United States, along with the heroin epidemic. In 2015, according to Centers for Disease Control and Prevention, heroin deaths alone surpassed gun homicides for the first time. More than 33,000 people died of opioid overdose, with another 20,000 dying from other drugs. A recent federal study found that prescription painkillers are now more widely used than tobacco. There also exists this gateway phenomenon. This is how it works. When a person starts using prescription pain medication, often for legitimate reasons, they can become addicted to it. However, prescriptions are expensive and controlled, and the person can't get enough of the medication. The answer to these problems can be the use of heroin, because it is abundantly available and inexpensive. This switching from prescription medication to heroin is the main reason behind the current heroin epidemic. Now that we have detailed some of the issues with respect to this alarming trend, the question remains, what can be done? Every treatment center should have heroin familiar staff, meaning staff specifically educated in the diagnosis and treatment of heroin addiction. Treatment should be affordable and covered by all insurance plans. We have to stop insurance-mandated discharges. This occurs when the insurance company stops paying for the treatment and the person is discharged too early, before their treatment is complete. Money, or a lack thereof, should not dictate someone's treatment course. The amount of time drug and alcohol counselors spend working on insurance matters instead of actual treatment with patients is astonishing. The next cornerstone is education, and it has to start early through our school system and at home. It is important that each school have an addiction consultant, someone who can educate the students and provide guidance when needed. In addition, it is important to educate the rest of the public. We have to carry that education even as far as our medical professionals so they can learn addiction awareness and responsible prescribing practices. Buprenorphine And naloxone, better known as Suboxone, is a medication that can be used in the treatment of heroin addiction. Suboxone is a combination of a mild opiate and naloxone. It can be used to detox an opioid addict, and it also has an indication for long-term use. It is especially helpful for people who have chronic pain, along with an addiction to opiates. It can only be prescribed by physicians who have specialized training in addiction treatment, and there is significant withdrawal if it is suddenly stopped. It relies on patient compliance as well. The withdrawal from heroin, or any opiate for that matter, is terrible for the addict. The individual won't die, but they will feel like they are dying. Suboxone can help these withdrawal symptoms and allow the addict to carry on with the work of treatment. It also helps protect against immediate relapse when taken as directed. Patients report fewer cravings when taking Suboxone, and the naloxone component will actually block the effects of heroin if it is used. So if a person who is taking Suboxone uses heroin, they get no rush. It can be a safety net for the recovering addict. They know that if they slip or relapse, the heroin will have no effect. The next tool is naloxone itself. This is a medication that can serve as an antidote to overdose. It can be used in the field for the acute treatment of an overdose. Emergency personnel are being trained to use this all across the country. It can be a real lifesaver in overdose situations. When discussing addiction, it is helpful to examine how this disease functions in the real world around us. We're going to go through a case presentation that highlights some of the issues we have discussed this far. Susan is a housewife. One day she was gardening and she hurt her back. The pain was bad enough that she went to her doctor and they tried some conservative things like a heating pad and anti-inflammatory medication. But ultimately her pain was bad enough that her doctor prescribed Vicodin, a narcotic pain medication that she had never taken before. Susan took the Vicodin and she noticed a couple of things. First, her back pain went away. But second, she developed a real connection to the medication. She had more energy after taking it. This type of pain medication makes most people drowsy. However, it is not uncommon for addicts to have the opposite experience. Susan generally felt better when she took it, and over time she noticed she felt pretty terrible when she wasn't taking Vicodin. So she started to take more and more. That's what we mean when we say she developed a connection to the pills. No pain, more energy, felt great, and she felt not so great when she tried to stop. Ultimately, her habit grew to the point that she could not get enough pain medication from her doctor, so she started to doctor shop. This happens all the time. She was getting her Vicodin from several different doctors, but ultimately she still needed more. So through a series of events, Susan went from the heating pad and anti-inflammatory medications for some back pain to daily heroin use. She started taking heroin because it was more available, and it was cheaper than the prescription pills. She bought it from a friend of a friend type of arrangement. Now, this doesn't happen every time, of course. People don't take Vicodin and then suddenly develop a heroin addiction. But it does happen. It happened to Susan, and it's happening every day around our country. It is important to examine Susan's family history as well. Her biological father died of alcoholism, and her cousin completed treatment years ago for an addiction to anxiety medication. Looking back, it seems obvious that Susan has some genetic risk factors for addiction. However, she never thought it would happen to her. She rarely drank alcohol and never used illegal drugs before these events. There's no guidebook for how to take heroin, so Susan injected too much one day and overdosed. Emergency personnel administered naloxone, and she was taken to the hospital. She went to the intensive care unit and ultimately had to confess to her doctor and her family. Her family was shocked but supportive, and she ended up going to treatment. She made a very good decision. So she went to treatment and did well. And she's doing well today. She lives a life of recovery, and she will forever have to be aware of her disease and continue doing the things that keep her healthy. That's great for Susan. But unfortunately, the story doesn't always end that way. So this switch from narcotic pain medication to heroin is happening all the time, and it's a very serious problem in our country and even worldwide. It can happen innocently, as with Susan. She wasn't taking pain medication to party and have fun. She had the genetics for addiction, and her back injury served as the starting point for her painful journey. In conclusion, let's review some of the information from this presentation on the opioid epidemic. Please remember that addiction is a chronic, relapsing brain disease. Addicts are not bad people. They are sick people who need treatment and support. Specifically, heroin is a major public health concern, and heroin addiction is on the rise due to several factors including cost, purity, and a concurrent increase in addiction to prescription pain medication. Education is mandatory and should start early in the home and in schools. Treatment has to be available for those in need. We at Next Right Thing know that the stigma surrounding addiction comes from ignorance, and we are committed to raising awareness so that addicts are treated and viewed no differently from people struggling with other diseases like diabetes or heart disease. Again, addicts are not bad people trying to get good. They are sick people who need help and support to regain their physical and mental health. You can always find more information about addiction on our website, nextrightthing.org. Thank you for your interest in the opioid epidemic.